Okay, welcome back. Let's pick up the story with prostate cancer. So, the thinking that what gets published in the peer-reviewed literature is that a benign prostatic hyperplasia incidence is like the canary in the mine shaft. You know, they put the canary down in the mine shaft, and I think if there's carbon monoxide, then the canary dies, and so they know we better not go down there because it's very scary. So the high incidence of benign prostatic hyperplasia in the Western world actually correlates with higher incidence of prostate cancer as well. Whereas in many parts of Asia and Africa and Eastern Europe, they have lower amounts of benign prostatic hyperplasia, and prostate cancer rates are also much lower. So that BPH incidence that we see, that we just assume is normal, the enlargement of the prostate as men get older, we think that's just a normal part of the aging process. But this is really the aging process taking effect, and our diet and lifestyle habits being so hazardous actually amplifies it and makes everything worse. The high animal fat diet, alcohol, obesity, lack of fitness, low vitamin D levels. We're going to see how all these pieces come together. Not enough omega-3 fats, alcohol consumption at higher amounts, and not enough protective nutrients. You'll see that these are the same things that tend to increase risk of benign prostatic hyperplasia are the things that tend to increase risk of prostate cancer. So the rate of prostate cancer is 80% higher in North America than it is in many parts of Asia and certain countries in Africa and Eastern Europe, where the diet and lifestyle habits are very different. So there's probably 80% of prostate cancer is preventable. That's really what the evidence suggests. However, 13 to 32% of men in all countries, even in the countries where men don't have clinically significant prostate cancer, all men from any country, from all different countries, if they were to die prematurely, let's say in a car accident, they do an autopsy on them, and they look at the prostate gland. Well, up to 32% of men, by the time they're 45 or 50, all have some cancer cells in their prostate gland. The difference is that you can have cancer cells in your prostate gland, but they might just lie there dormant, a small little cluster that never really bother you, or they never become clinically significant. But if you're putting fertilizer on that group of neoplastic cells, then that promotes them to grow and divide and multiply and spread. And our dietary and lifestyle patterns in the Western world seem to be the fertilizer that makes things worse over and above just the aging process, inducing some of these changes to initiate it. You need progression, and you also need the other things that drive the promotion of cancer, and that seems to be diet and lifestyle based to a large degree. So we'll keep looking at this. Low risk countries show up to an 80% lower progression to significant disease. So that means that even though men in, let's say, Japan have prostate cancer at age 45 at the same incidence we do in terms of small clusters of cancer cells, 80% of these men never really promote that cancer to develop into a significant tumor. Whereas 1 in 7 men in Canada develops prostate cancer, and 1 in 27 men in Canada will die from it. So that's a very common cancer. So prostate cancer is the second leading cause of cancer death after lung cancer in Canadian men. Same with U.S. statistics. So here you see prostate cancer stats from around the world. This is what I'm talking about here. You look at the United States up here at the top, and so you see the incidence of prostate cancer, and then the deaths, right, per 100,000 males. And Sweden in the Western world, here you see Canada in the Western world, Switzerland, Australia, France, and so on, all down the line. And then when you start getting into these Asian countries, you start to see lower incidence. I mean, it's dramatically lower. And it's not because they die prematurely. I mean, we're talking, these people have normal lifespans, and their prostate cancer incidence is tremendously lower. And this is explained not by genetics. This is explained by diet and lifestyle patterns, because when people from these countries migrate to Canada, the United States, and elsewhere in the Western world, and they adopt the dietary habits that we have and our lifestyle habits, within one generation, their cancer rates are just as high for prostate cancer and colon cancer and breast cancer. Let's keep going. Here you see in the United Kingdom, you see around age 40 or 45 or 50, that's when things start to take off. This is when cancer rates in the prostate really take off. And this is at the point where testosterone is more rapidly becoming dihydrotestosterone. That's the point, that this is a critical time in a man's life to start putting prostate nutrients in to block the buildup of DHT, inhibit angiogenesis, induce programmed cell death of any existing prostate cancer cells, put in the androgen blockade, the estrogen blockade, stop the conversion of androstenedione into estrone hormone. All these things bring down that incidence. Here you see Canada. What's a little bit encouraging here, look at the stats in 1995 here of prostate cancer. This is the age-specific prostate cancer incidence, ages 40 and older, right? So you see that the blue line is 1995, and the red line is the year 2012. So there's been some improvement in recent years in Canada, and that's really nice to see. And so what we really are seeing to a large degree is that you're still getting 1 in 7 men developing prostate cancer in their lifetime. But prostate cancer deaths, all the deaths from cancer, 10% of them are prostate cancer related. So it's still, it's the second leading cause of cancer death. And really what I was sort of alluding to, we'll get to this, is that since the introduction of the PSA blood test, the prostate-specific antigen blood test, say around the year 2001 when it became most prevalent. Since then, because the PSA helps to find cancers earlier, doctors can intervene sooner to save the person's life. Because once prostate cancer spreads beyond the prostate gland, beyond the capsule of the prostate gland, into the surrounding tissues or the lymphatics, it's very hard for medical treatment to be effective. But if you can catch it early when it's still contained within the prostate, hasn't spread outside the capsule, the success rate is extremely high. So prior to the prostate-specific antigen blood test, there was no way to detect prostate cancer early. All you could do was a digital rectal exam, and you could only feel masses in the posterior part of the prostate. You couldn't feel any other zones or tissues around there. And once you found a mass that you could actually feel, it was already too late. It was already too large, and it had already spread. So the PSA blood test is really the thing that has been the turning point, and it can be life-saving. It is life-saving in my view. So this is stats from the Canadian Prostate Cancer, the Canadian Cancer Society. 1 in 7 men will be diagnosed with prostate cancer in their lifetime, right? Prostate cancer is the most commonly diagnosed cancer among Canadian men, 21%. An estimated 21,000 men will be diagnosed during this year, and 4,000 will die from it in 2017, roughly. The death rate has been declining significantly by an average of 3.3% per year since 2001 from improved testing for prostate and better treatment options. And so that is absolutely true. That PSA blood test is really important. Once it rises beyond a certain point, they do a biopsy, and they look at suspicious areas, and they do a histological look from a pathologist standpoint. If there's prostate cancer, there's different types of interventions that can treat the prostate and prevent it from becoming a widespread metastatic disease. But look at the age group from age 50 to 69 years old, right? 18% of all newly diagnosed cancers in that age group are prostate cancer. Now for women, 14% of all newly diagnosed cancers are breast cancer, 14% across the board would be lung cancer, and 12% are colon cancer. So after the age of 50, all these cancers start to increase in incidence. And it's also the time in a person's life where the immune system starts to become less intelligent, more sluggish, not as, the thymus gland has undergone involution. It's easier for cancer cells that are there to actually start to get some traction because you have the immune system's not knocking these cells out as easily. That's the other thing, immune modulation after the age of 50. We've talked about that in theories of aging. So because all 4 of these cancers are related to some degree to diet and lifestyle, because a certain percent are just strongly genetic, but that's a small number. 58% of all newly diagnosed cancers involve cancer types in which their development is known to be highly influenced by diet and lifestyle, and where early detection is available. And so this is why you see your doctor and you get the screenings done in an appropriate fashion. PSA, mammogram, chest x-ray, colonoscopy. There you go. So with respect to prostate cancer, it's an adenocarcinoma. So prostate cancer is classified as an adenocarcinoma or glandular cancer. So it's the cells of the prostate glands that undergo cancerous change. So it begins when normal semen-secreting prostate gland and cells mutate into cancer cells. Now, the region of prostate gland where the adenocarcinoma is most common is the peripheral zone. Initially, small clumps of cancer cells remain confined to an otherwise normal prostate gland, prostate glands rather, a condition known as carcinoma in situ or prostatic intraepithelial neoplasia, or PIN, P-I-N. So these would be sort of precancerous cells, really. Although there's no proof that PIN is a cancer precursor, it's closely associated with cancer. We're pretty sure from studies we've seen subsequently that prostatic intraepithelial neoplasia is a precursor to the development of cancer. What we're going to see down the road is that in men that have these precancerous lesions, if you give them supplements with green tea catechins, it can actually reverse that back to normal or stop it in its tracks. And the men that get the placebo, the 27% higher rate of it becoming prostate cancer within the next 12 months. So there are we're going to look at this in the supplement section in the adjunctive nutritional management of cancer, the studies that show that you can alter even these neoplastic cells if they are present, these pre-neoplastic cells. Over time, these cancer cells begin to multiply and spread to the surrounding prostate tissue, forming a tumor. Eventually, the tumor may grow large enough to invade nearby organs such as the seminal vesicles. Some cancers just invade tissue that are directly adjacent to it by secreting these metalloproteinase. We're going to see them there. They break down the hyaluronic acid barrier between tissue so they can invade the next cells, and then they get into the seminal vesicles or directly into the rectum. Or the tumor cells may develop the ability to travel in the bloodstream, as we saw earlier, or sort of slide into the lymphatic system and spread to bone and to liver. So prostate cancer is considered a malignant tumor because it is a mass of cells which can metastasize, most commonly to bones. So prostate cancer cells are able to, once they get into bone, to sort of morph into tumor cells that can form beautiful colonies inside bones, including the spinal vertebrae, by the way. They can also get into lymph nodes, spread to the rectum, to the bladder, also to the liver, which you're not seeing there, but the liver is another organ where after it goes to bone, it often goes to the liver. So there's some genetic risk factors for prostate cancer that have been identified. I don't want you to think that I think that all these cancers are only based on diet and lifestyle. Let's look at some of this genetic stuff. Studies on twins in Scandinavia suggest that up to 40% of prostate cancer risk can be explained by inherited factors. Now, that doesn't mean that if you inherit the gene, you're automatically going to get the disease. A lot of these people that have the inherited gene don't actually get the disease. But up to 40% in cases under 45 years old. So if you're in individuals who develop cancer early, largely that's genetic, but closer to 25% of all the total cancer cases, which we were saying earlier, that 80% of prostate cancer seems to be preventable. Well, maybe it's only 75% according to the Scandinavian studies. But no single gene is responsible for prostate cancer. That's the thing. There's many different genes that have been implicated. Two of the genes, the BRCA1 and the BRCA2, seem to be important they're also important for ovarian cancer and breast cancer in women, but they've been implicated in prostate cancer for men as well. And we'll talk about BRCA1 and BRCA2 when we talk about breast cancer. You'll see how the BRCA1 and BRCA2 gene, they code for an enzyme that actually is a DNA repair enzyme. So if a certain gene breaks or mutates, the BRCA1 or BRCA2 can get in there and fix the mutation before it becomes a permanent cancer mutation. But if the BRCA1 and BRCA2 genes don't work because you inherited genes that don't work, then if the certain proto-oncogenes break that can lead to cancer, if they're starting to break and you can't fix them, then it's easier for cancer to take hold. Genetic risk factors. Having a brother or father with prostate cancer doubles your risk. A brother is a stronger risk indicator. Having a mother with breast cancer may increase risk, so especially if she has like BRCA1 gene mutation, or BRCA2. And blacks have a higher incidence of prostate cancer than Caucasians. Some of the evidence is suggesting that it might be due to vitamin D polymorphism, so they can't get that vitamin D into the cell to sort of slow down the rate of replication, or help. Vitamin D helps cells fully differentiate as well into beautiful mature adult cells, and they're less prone to cancer change. Or it might be that darker skin inhibits the ability of sunlight to convert 7-dehydrocholesterol into cholecalciferol in the skin, so you're making less vitamin D. So you need more vitamin D to raise your 25 hydroxycholecalciferol, your blood vitamin D level. For someone who has darker skin, it's harder through sunlight to get that blood level up. And so this is where supplementation, we think, becomes an important factor for a lot of people to get their vitamin D into the ideal range. It's strongly linked to prostate cancer prevention. So let's talk about prostate-specific antigen screening, the PSA test. So the 2007 National Comprehensive Cancer Network guideline recommends offering a baseline PSA test and digital rectal exam at age 40 and 45, right? So that's the baseline. You get your first baseline done at age 40 and 45. And then an annual PSA test beginning at age 50 through age 80. So every year you get PSA done for every year from age 50 to 80, along with information on the risks and benefits of screening. So doctors should say, listen, we're going to do this blood test. Here's what it means, and once we get the results, if the numbers are high, it might mean that we want to do a biopsy, and with biopsy comes the risk of infection, and there's some bleeding, and sometimes it's uncomfortable, and even if there is prostate cancer there, sometimes that prostate cancer is not that significant, so sometimes we do major procedures like a radical prostatectomy, whereas in the majority of cases it's such a slow-growing tumor that it's not really life-threatening anyway, and then you have to make all these decisions about what to do. So that's the kind of, when they say along with information on the risks and benefits of screening, that's what the discussion is. However, annual PSA testing and the digital rectal exam should begin at age 40 for African American men. So don't wait till age 45. Get that started at age 40. The annual test, not just the baseline, annual. And men with a family history of prostate cancer. Men with a PSA that's at or above 0.6 nanograms per milliliter at age 40. Or a PSA that's above 0.6 nanograms per milliliter at age 45. So this is these are the people you want to take more seriously, more vigilant screening. The biopsy is recommended if the digital rectal exam was positive, you can feel a mass, or the PSA level is above or at 4 nanograms per milliliter, and biopsy is considered if the PSA is just over 2.5. or the PSA velocity is rising on a yearly basis at a rate that's faster than or equal to 0.35 nanograms per milliliter, even if the PSA is under 2.5. So just a rise in the velocity within the normal range is a bit scary. And you see the other inclusion factors. Some U.S. radiation oncologists and medical oncologists who specialize in treating prostate cancer recommend obtaining a baseline PSA in all men at age 35, or beginning annual PSA testing in high-risk men at age 35. So they want to even, dial it back further and start more screening at an earlier stage where there's people at high risk due to family history. However, PSA tests may lead to overdiagnosis, so that's the thing. But I will tell you, I think the PSA test is a spectacular innovation. With additional testing and treatment, follow-up tests such as prostate biopsy may cause pain, bleeding, and infection, or possibly, if there is a tumor there and you put the needle in, you're stirring it up, and it might actually cause the cancer to spread. That's why some men don't like to have anybody poking around in there. But I just think if your PSA is above 4 and nutrition and lifestyle interventions are not bringing it down, you should have the biopsy. Prostate cancer treatments may cause urinary incontinence and erectile dysfunction. which can affect quality of life. So let's say they discover you have a low-grade prostate cancer that's localized to the prostate gland. They say, well, okay, well, look, we're going to do radiation therapy to destroy the prostate. Well, that comes with consequences of, erectile dysfunction, urinary incontinence for a while. Not all the time. If they do a radical prostatectomy, they take the prostate out, there's a good chance they're going to damage nerves, and you have erectile dysfunction problems, urinary incontinence, with a prostate cancer that may not have been that important in the first place. So these are the big questions about what to do. I think once the Gleason score is above 5, and we'll talk about the Gleason score, I think you need to act on this. You have to go and have that prostate treated. In most cases, prostate cancer is slow growing, and the person usually dies from other causes. So that's why being aggressive in your prostate cancer treatment might sort of have been unnecessary, and you change the person's quality of life. They have trouble having sex, and they're wearing a diaper, and maybe all this wasn't even necessary. But we're seeing that the PSA testing and interventions overall are saving lives and bringing down the incidence of prostate cancer mortality. Therefore, it's essential that risks and benefits of diagnostic procedures and treatments be carefully considered before PSA screening. Prostate cancer is the second leading cause of cancer death in men after lung cancer. Since no firm evidence or general agreement that benefits of PSA screening outweigh the harms, major scientific and medical organizations recommend that clinicians use a process of shared decision-making with the patient that includes discussing with the patient the risks of prostate cancer, the potential benefits and harms of screening, and involving the patient in the decision. So, once it's all explained to the patient, they can say, you know what, doc, I don't want to be screened. I'll just take my chances. I don't want to know. I'm not worried about this. If it happens to me and it becomes aggressive and it ends my life, I'll deal with it. But there's a good chance that you'll find a cancer in my prostate gland that's not even that significant. You'll do all these radical things, and it'll change my quality of life, and maybe it all would have been unnecessary. I just don't even want to go down this path in the first place. So people have the right to make informed decisions about that. The PSA test measures the blood level of the prostate-specific antigen. So what is that? That's an enzyme that's produced by the prostate. Specifically, the PSA is a serine protease that helps liquefy the gelatinous semen after ejaculation, allowing the spermatozoa to more easily navigate through the uterine cervix. So that's the purpose of the enzyme. PSA levels can change for many reasons other than just prostate cancer. Two common causes of high PSA levels are prostate enlargement. So just having an enlarged prostate that's inflamed or infected can actually raise the PSA. Doesn't mean you have cancer because the PSA is high. So then they go in and they do biopsies and they poke around and you get an infection or bleeding, and it's like, oh, there's no cancer there, and we caused all these problems, and it was really just inflamed or it was just enlarged. It can also be raised for 24 hours after ejaculation and several days after catheterization of the urethra. So if you have a catheter in, and having a PSA test done, within the next day or so, can give you a false positive. But the same is true if you're going to have a PSA test done. A man does not ejaculate for 24 hours at least prior to the test, so you don't end up with a false positive and the alarm bells go off because the PSA is high. Measuring the amount of PSA which is free or bound may provide additional screening information, but questions regarding the usefulness limit their widespread use. So normally on the requisition form, the doctor can order the PSA test, and also they can look at the PSA sort of, is it bound or unbound, but normally you just have a PSA test. If your PSA level is below 1 and you're, let's say, over the age of 60, then there's no need to go on and do these other tests, to be honest with you. Although the digital rectal exam only evaluates the back of the prostate, 85% of prostate cancers arise there. Prostate cancer, which can be felt on the digital rectal exam, is generally more advanced. So once you can feel it, I must tell you, it's pretty much too late. The use of digital rectal exam has never been shown to prevent prostate cancer death when used as the only screening test. By the time you can feel it, it's likely too late for a doctor to put a life-saving measure in place. And so if the prostate cancer spreads outside of the prostate capsule, and it starts to metastasize, those prostate cells are still, in the early stages, usually dependent upon testosterone and dihydrotestosterone, to stimulate their cellular replication. But then after a while, so what they do is they give men these drugs and procedures that are going to work as testosterone ablation treatments. They either castrate them, take the part of the testes that synthesizes testosterone, remove that, or they give them drugs that sort of inhibit testosterone production, has sort of an estrogenizing effect, and you block the testosterone stimulation of those cells. So the thinking was, well, if we can do that, then the prostate cancer cells won't divide and we can contain this disease. But what happens is the prostate cancer cells undergoing that kind of hormone therapy, if you can call it that, what they do is they morph and they start to build their own what are called heat shock proteins. You see them here with my cursor showing it. So they start making heat shock proteins and they just self-stimulate. And they just send their own messages down to the DNA to tell the cell to keep dividing and dividing and dividing. They just amplify the whole process. You don't even need testosterone or androgen stimulation because the cells will morph and they'll produce what are called heat shock proteins and glucose-related molecules that will just internally keep the switch turned on. And so these hormone replacement therapies and these testosterone ablation therapies ultimately fail. There's no real treatment that's effective for men once the prostate cancer has spread outside beyond the prostate capsule. That's why catching it early is so important, and putting in place lifestyle measures to prevent this from even happening in the first place. This is so critical. All right. I think we're gonna just take a break there. The one last thing I wanted to mention is that when they look at prostate cells, they want to know, just when they look at breast cancer cells, they usually want to give them a certain type. Is it triple positive or triple negative? So with breast cancer, they're looking at, is it estrogen positive receptor? Is it progesterone positive receptor? Does it have the HER2 receptor on it? So you're looking at, do the cancer cells have estrogen receptors, progesterone receptors, and or the HER2 receptors? That's for breast cancer. For prostate cancer, they want to know, are these cells androgen dependent or androgen independent? Because the androgen dependent prostate cancer cells, if you can get those cells from the body and a pathologist looks at them, they go, oh, so if it's androgen dependent, it really depends on testosterone for its growth. We can basically give the person testosterone ablation therapy and it will work for a while. But the cells that are androgen independent, they don't even have androgen receptors, they're just, as you see in the model over here on the right-hand side, they're just amplifying, they're just producing their own signals to cause stimulation of the tumor. They even in the beginning don't even need any hormones. See over here, the androgen dependent ones, at first they need dihydrotestosterone to stimulate them, and then they kind of morph often into androgen independent, then they just basically create their own coactive signals that actually just drive replication, and they don't need hormones anymore. So on that note, we'll take a break. We'll come back, and we're going to talk about what we know about nutrition and lifestyle influences on preventing prostate cancer in the first place. That'll be the next thing that we talk about. So I'll see you after the break.